Good afternoon, everyone. Welcome to our webinar. My name is Dr. Andrea Huseth. I am an associate professor in the NDSU Department of Public Health, and I'm here to welcome you to the Department of Public Health seminar series. Today's seminar will be presented by Dr. Paul Carson, and the title of his seminar is Long Haul COVID-19, the Next Looming Pandemic. Dr. Carson is an infectious disease physician with over 25 years of clinical experience. He is board certified in the specialties of internal medicine and infectious diseases. He is also a professor of practice in the North Dakota State University Department of Public Health and the medical director for the Center for Immunization Research and Education, also known as CIRE. Please welcome me in introducing Dr. Carson.
Great, thank you. So today I'm going to be talking about what is commonly referred to as long haul COVID. And just by way of introduction here, we have a pretty mixed audience. Normally our public health seminar series is to the university community. And because there's a lot of interest in this topic, we've opened it up to healthcare facilities and healthcare workers. And actually, that's also for continuing medical education credits. And we've opened it up also to the media and some of the general public. Because we're offering it to healthcare workers for credits, some of the content here is going to be a bit technical, and I know that might seem a little bit out of bounds for some folks. Most of it, I think, will be understandable, but you can post questions in the Q&A section if something seems a little bit confusing or hard to understand, and I'll be happy to, I or some of our team will be happy to try and answer those towards the end of the presentation. So for disclosures, I can disclose that I and our team and the people hosting the conference and the UND School of Medicine that's providing the continuing medical education have no conflicts of interest. We take no money from pharmaceutical companies or any other things that might be mentioned in the course of the talk. So we're kind of free of commercial conflicts of interest. We will discuss potentially some of the treatments and vaccines that don't have full FDA approval. So those are considered off-label, if you will. And we will discuss some of that. For those who are wanting to obtain continuing medical education credit, please take that pre-test. You can get that at the link shown here. And that I think also is in the chat. And then there will be a post-test at the end so that you're able to claim the continuing education credits for that. So there was a kind of provocative opinion piece in the New England Journal of Medicine. This was almost a year ago, I believe, talking about confronting our next national health disaster, long haul COVID. And these writers were making kind of the prediction of a host of problems that we might be seeing in clinical practice and in public health in the wake of our COVID pandemic. And I want to kind of go through what we might be expecting with some of that. So just to kind of start, maybe even a little bit before that, we frequently hear questions like this or comments like this. 99.9 or 99.99 or 99.97%, all kinds of sort of numbers thrown out there, but very, very high percentage of people with COVID survive. I'm healthy, I'll take my chances. So that may be true if you're a young man like this, but just to kind of put a little bit of a greater light on that, the actual overall case fatality rate. So that is, of all the people who show up as a case, meaning they felt sick enough to present to be tested, what percent of those people die? It's the overall what we call crude case fatality rate in the United States is between 1.2 to 1.6%. So it's not true that 99.9% of people survive. It's very variable depending on your age and your underlying health status. But 1.2% of an overall for an overall case fatality rate in the world of infectious diseases is actually pretty high, something that we would take very, very seriously. But beyond that, we might ask the next question is, what might survival look like? Survival might look like landing in the hospital. This is the overall percentage of people by age group who will land in the hospital from COVID if they contract that and show up as a symptomatic case. Note that if you're over the age of 65, you're pushing 42, 43% of those folks may land in the hospital. Around 18% of people in their 50s to early 60s. Even children have, age 5 to 17 may have 3-4% of those landing in the hospital. And young children are a little bit worse. They tend to develop more severe symptoms, often don't have a fully developed immune system until well into their first and second year of life. And so that rate of hospitalization approaches 6 to 7%. We've had in the news, these are not cases that I'm disclosing any protected information. These were from news stories in our local news. These very notable cases of people who suffered greatly. The example of this young man, Brady Monroe, who was 23 years old at the time, healthy, played football for Valley City State, was engaged to be married, came down with COVID and landed in Sanford's intensive care unit for 100 days, most of that time on the ventilator, and had multiple different complications along the way that threatened his life. He, thank goodness, is home now and I believe is recovering, but that can be a long haul, if you will, no pun intended there. That can be a long haul trying to recover and rehab from a protracted intensive care unit stay like that. In Williston, we had in the papers and in the news there, the young woman, Nicole Roberts, who had given birth to her first child. I believe she was in her early 20s, had tested positive for COVID around the time of her delivery. And in the ensuing week, developed severe respiratory distress, had to be sent to the University of Minnesota Hospital, was put on artificial life support, and I believe is still there. I'm not certain on that, but I know has been there for at least 3 months, fighting for her life in the ICU, and a long, long battle trying to survive and recover from her very severe COVID illness. So we know that most people who land in the hospital with COVID have an underlying health conditions, but as the two examples I showed before, not all of them do that. Here are some of the typical underlying conditions that have a predilection for putting people in the hospital. Very common conditions: high blood pressure, obesity, diabetes, underlying cardiovascular disease, neurologic problems, chronic lung disease, kidney, maybe asthma. That's bearing out more so in children as a risk, maybe less so in adults. And immunosuppression can be a big risk, although that's not as common in the general population. But when you kind of think about, people saying, well, they had underlying conditions, that's not me. If you look in the United States, the prevalence of any one of these underlying medical conditions that put you at risk for a severe COVID-19 outcome, you can just kind of see the counties that are in darker blue and black have very high prevalence of these conditions. And on average, around the country, the median county prevalence for the population having any one of those medical conditions is about 47%. So it's almost half of us have one or more of these underlying conditions. And age is the biggest predictor for a more serious outcome from COVID. And that, just to note, about 16% of the population in the US is over the age of 65, which would be the largest predictor of a more serious outcome. And then it doesn't really stop after hospitalization. So I'm talking about hospital cases here, and it's still talking about acute COVID, not getting into long haul COVID, but just to kind of put a finer point on what does it mean to potentially survive. This was a British study looking at over 47,000 people who had been hospitalized with COVID-19 in 2020. They followed these people up for just under half a year after discharge, found that almost 30% of them ended up being readmitted to the hospital, and 12% of them died later after their hospitalization. A lot of these deaths will not be counted as a COVID death. So we actually might be underestimating the number of deaths attributed to COVID, and the risks and the problems that come from that don't end with getting out of the hospital. And then more to the point is what we're going to talk more about today is the issue of long COVID, or what is sort of colloquially called long COVID. And that's these lingering effects after a COVID diagnosis. So first we need to try and get a definition of this. And we don't have a fixed definition of this yet. The World Health Organization is taking a stab at trying to define this. And actually the more clinical term isn't long COVID, it's post-acute sequelae of COVID, or sometimes abbreviated as PASC, P-A-S-C. The WHO defines this as a condition that occurs in individuals with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that last at least 2 months and cannot be explained by an alternative diagnosis. Symptoms may be new following initial recovery from an acute COVID-19 episode or persist from the initial illness. Symptoms may also fluctuate or relapse over time. The most common ones of these are fatigue, shortness of breath, cognitive dysfunction, and others which generally have an impact on everyday functioning. Our coding system, which we use to define clinical conditions for coding purposes in healthcare systems, also called our ICD-10 codes, now have a specific code for this, UO 9.9, and it's also now considered a disability that's potentially covered under the American Disabilities Act. So when you kind of expand and look further at some of the most commonly reported symptoms, there's quite a list of these. Shortness of breath, fatigue, more fatigue after you exert yourself, brain fog or cognitive impairment, persistent cough, chest pains, headaches, palpitations, muscle and joint aches, and so on and so on. We're going to dive into these a bit more deeply to look at which ones are common and which ones are not. So when you kind of look at SARS-CoV-2 exposure, we usually have the acute illness and ability to detect the virus in the first week or two after exposure, and symptoms and signs of an ability to detect the virus fade over time, but multiple different organ systems may be affected. And it's then getting out, 12 weeks to 6 months, we may find these constitutional symptoms starting to appear, respiratory symptoms, mood disorders, cardiac problems, blood clot propensity, kidney problems, and even hair loss has now been described. In a very comprehensive, systematic review of the literature, the medical literature out there on this, so a recent publication in the Journal of the American Medical Association tried to undertake this very large, comprehensive, systematic review. They looked at 2,100 published studies that have already appeared on this issue of long COVID. They actually decided only about 57 of those were really high enough quality to try and determine potential rates or prevalence of the various symptoms that come along with long COVID. In these 57 higher quality studies, they were able to review about 250,000 patients. Most of these in this systematic review were inpatients, almost 80%, and they were followed variably from 1 to 6 months. So this isn't quite the WHO definition yet, but it does get to the idea of prolonged symptoms anywhere from 1 to 6 months out. And you can see, even when they followed and looked at the studies that were only 1 month out, studies that were 2 to 5 months out, studies that were 6 or more months out, the rates were about the same, a little over 50% prevalence of one or more of these post-acute sequelae of COVID symptoms going out over these periods of time. Pretty high. Furthermore, they found no significant differences in high-income versus low-income countries, and they didn't find really much in the way of differences in the studies that had high rates of hospitalization versus low rates of hospitalization. I'll get more into the risks of this in outpatients here in a moment. But very high reported rates of one or more symptoms in these 1 to 6 month out intervals of time following a COVID diagnosis. What were the most common symptoms that they reported? Chest imaging abnormalities, symptoms or findings, I should say. Chest imaging abnormalities in 62%, general functional impairment in 44%, fatigue 38%, general anxiety disorder, most of the time being a new general anxiety disorder, in 30%. Difficulty concentrating reported in 24%. I mean, these are substantial symptoms and some overt objective findings like chest imaging abnormalities in very high numbers in people looking out after their COVID, at least 60 days or more after follow-up. Another study that looked at this in hospital survivors 1 year out from their hospitalization from COVID, found at 6 months, 68% had one or more of these problems. But even at 12 months, nearly half still were having problems, most often fatigue, sleep problems, smell problems, anxiety or depression, persistent abnormality on a CAT scan of a chest in 39%, abnormal gas exchange in the lung, 23%. I mean, these are substantial objective findings of lung impairment, and ongoing shortness of breath in 30%, a year out from hospitalization. When you look at people's ability to get back to sort of normal functioning, here's another couple of studies that looked at this. One, a retrospective study of 1,300 hospitalized patients discharged to home. Only 40% of them were independent in all of their activities of daily living at 30 days. So this is not a super long follow-up, only 30 days, but still 40% independent, 60% still needing help with one or more of their activities of daily living. Another study, almost 40% unable to return to normal activities at 60 days. So getting a little further out, 2 months out, still substantial percentage of people struggling to do their normal daily functioning. When we look at post-COVID-19 symptoms in outpatients, this was a study in another area, the Faroe Islands. They had a captive audience that they could study there, a relatively small study here, only 180 subjects, but a high follow-up rate, 96% follow-up in the people that they were looking at after COVID. And in here, it's almost a little over 4 months after their COVID diagnosis, 53%, again, that kind of halfway mark of people having one or more symptoms ongoing after their COVID. Most often fatigue or weakness, loss of smell, loss of taste, headaches being the most common in outpatients. Another study in outpatients, 6 months out. This looked at prolonged symptoms and the percentage of people who had one or more symptoms 6 months out from their COVID. You can see that people over the age of 65, almost 43% of them having one or more symptoms. But even young people, 18 to 39, about 27% of them having one or more symptoms 6 months out of their, from their mild to moderate outpatient illness. So not severe disease. Most often, this was fatigue, persistent loss of taste or smell, and shortness of breath. Another study kind of confirming this, looking at post-COVID symptoms, now 1 year out, again, primarily in outpatients. And again, I just plucked out the younger population because like I showed in that earlier slide, the young man who said, I'll take my chances with it. Here, 18 to 47-year-olds, even a higher rate reported here, 69% saying one or more symptoms, and over a quarter to a third having a variety of these different symptoms. So pretty high rates of what we consider morbidity in these people 6 to 12 months out, even outpatients, people with outpatients. I'm sorry, this one wasn't just outpatients. This was both hospitalized and outpatients, and they did not note any significant differences in outpatients versus those in the hospital. Now, going back to these studies I just showed you, these rates seem high. When I talk to a lot of my friends and colleagues and family members who've had COVID, I do hear some of these problems, not quite to the degree that's reported in a lot of these studies. And I'm going to throw a little bit of cold water on some of this data, and I'm going to try and sort of dry some of that cold water off here in a second. So all of these types of studies are prone to what we call selection bias, that the people who respond to the request for surveys, or the people who respond to say, yeah, I'll participate in your study, are often the ones more likely to have problems. Ideally, what we'd like is a control group. And so we look at like people who didn't get COVID, similar age, similar sex, similar demographics, and only a handful of these studies had a decent control group. One study that like I said, I'll throw a little cold water on this, was a French study that oddly showed that belief in having COVID seemed to be more predictive of having long COVID subjective symptoms than actually a positive antibody test for COVID. So they looked at 26,000 French citizens who had previously done a serologic survey looking for proof of prior infection from SARS-CoV-2 by the presence of antibody tests. And they looked and surveyed them later for 18 subjective symptoms lasting at least 8 weeks. Little over 1,100 of them had a positive serology. About a little over 900 had a belief that they had COVID. Actually, only 48% of them actually were seropositive for COVID. And oddly, that belief was strongly correlated with all 18 self-reported symptoms, where the serology was only correlated with loss of smell. So that might make you a little circumspect about these subjective symptoms. I would just point out this is one study. It does have this control group of people who were seropositive versus seronegative. But we have a similar study here that was done in the United States. These were healthy healthcare workers looking at that sort of seropositive versus seronegative, and their effects on work life, social life, home life, and what percentage of them had functional impairment based on whether they were seropositive, an objective measure, versus seronegative. And you can see that the people who were seropositive had substantially higher rates of impairment in work, social, or home life compared to those that had no antibody evidence of prior infection. About 15% of the seropositives having at least one symptom beyond 8 months, compared with only 3.4% of seronegatives. So we had that French study, but here's an equivalent American study that did show very substantial differences in people with objective evidence of COVID infection with a negative control group. Although that 15% having one or more symptoms is lower than those other survey data that didn't have a control group. You might rightfully ask, well, is this any different than other illnesses like influenza? And this was a study that looked at long COVID type features in people with COVID versus influenza. Here it's 1 to 180 days out, and here it's that just latter half, that 90 to 180 days out. And in both groups, more so early on, but even persisting out to the latter, further out from the time of diagnosis, COVID patients fared worse than people with influenza, although both did have some lingering problems or symptoms. COVID substantially higher, though. Let's look at some of the specific organ systems that may be affected by COVID. So going back to that systematic review of these, 2,100 studies boiled down to 57 good studies, 250,000 patients. Let's look at the respiratory problems. Well, they found evidence of lung fibrosis, a restrictive pattern on spirometry, meaning you can't expand the lungs very well, persistent cough, certain types of infiltrates on chest X-ray or CAT scan, shortness of breath, abnormalities in gas exchange, persistent imaging abnormalities, and the need for oxygen, ranging anywhere from 5, 6, 7% down to almost 60% of people needing oxygen for a while after their diagnosis. And this, again, is follow-up out to 60 days or more. So here we have more objective findings: needing oxygen, having persistent abnormalities on chest imaging, having abnormal gas exchange. These are much more serious lingering problems, lung scarring, evidence of fibrosis in the lungs, not inconsequential numbers here. Getting to more specifics, here are a couple of smaller studies that I thought were notable. One of these studies was in a Chinese group, 55 Chinese patients who were followed after their diagnosis of COVID pneumonia. At 3 months, 64% of these people had persistent symptoms. 71% had interstitial thickening or fibrosis on the CAT scan. You can see these examples of these abnormalities persisting on CAT scan. This is more the acute illness. This is the scarring that's left over. You can see these acute infiltrates clearing, that are there at the beginning, clearing here, but leftover residual scarring evident. And 25% of these subjects had a decrease in their carbon monoxide diffusion capacity. That's a measure that we do of the lungs to exchange gases. And so that's a substantial portion having impaired gas exchange at 3 months out from their diagnosis. Similar study of 57 patients 30 days after discharge. Here, it's not as long afterwards, but half having decreased carbon monoxide diffusion capacity or abnormal gas exchange. One of the questions that's been raised is, does asymptomatic COVID infection, because we hear a lot of people who test positive but maybe had minimal to no symptoms, does that mean no harm? This actually was kind of looked at in, some of you may remember the Diamond Princess cruise ship that was docked off of Japan. They wouldn't let them come ashore because they were having an outbreak moving through the ship. Then they were able to isolate and quarantine most of these passengers, and they ended up studying them quite intensively with a number of different types of studies. They found that 76 of the Diamond Princess passengers had an asymptomatic case of SARS-CoV-2 infection, but they all got CAT scans of the chest. So the Japanese did a lot of testing here. Of those asymptomatic cases, 54% had what we call ground glass infiltrates on their chest X-ray. So they had essentially a silent pneumonia that was going on that sometimes can lead to scarring afterwards. We don't really know what this may do to people in the long term for their respiratory function or pulmonary function. Bear this study in mind when I get to a couple of later studies on performance in athletes and what COVID may do to athletic performance. Moving next to the brain, we're finding a number of effects that may occur in the brain. So going back to that systematic review again, 57 studies, 250,000 patients, looking at neurologic and mental health problems after COVID, headaches persisting, taste disorders, smell disorders, cognitive impairment, memory deficits, difficulty concentrating, anywhere from around 10 to 25% of these post-COVID patients 2 or more months out having these lingering problems. On the mental health side, basically meeting the criteria for post-traumatic stress disorder in a little over 10%, depression 20%, sleep disorder around close to 30%, and generalized anxiety disorder around 30%. Again, substantial mental health and neurologic problems that may linger in a fairly substantial percentage of people after their diagnosis of COVID. A study that I think should give us all great pause about kind of just letting COVID go, or, kind of saying, well, it's inevitable. I'm going to get this, kind of giving up on it, if you will, or not doing your best to try and prevent infection. This study, I think, particularly should give people some pause. So this is called the UK Biobank study. This is a study that is ongoing in the United Kingdom. It's what we call one of these prospective cohort studies, where they follow a large population of people over a prolonged period of time to look at all kinds of different predictors of health or disease. So what you eat and how much exercise you do and what kind of exposures you have in the workplace, et cetera, et cetera. And then looking down the road for what kind of health problems develop depending on what kind of exposures you have. As part of their study, they're drawing blood on these people, and they're getting a very fancy MRI scan of the brain at very regular intervals over several years. Investigators of this ongoing study said, we've got a unique opportunity here in our UK Biobank population. A lot of our study subjects got COVID in 2020. We have all this data on what their brains looked like before COVID, and we can get a follow-up same kind of MRI scan after their diagnosis of COVID. They found that they had 394 of their study subjects who had a diagnosis of COVID, and they were able to match them up pretty well for age, sex, prior health status, with 388 of their study subjects that didn't get COVID. And they said, let's look at what their MRI of the brain looks like in the COVID versus the non-COVID infected subjects. What did they find? Well, first, they found that there was some changes in 56 to 62% of the subjects who had COVID. What did they find? They actually found that gray matter of the brain, that's the sort of surface layer of the brain, shrank in 5 different areas of the brain. And it just so happens that these 5 areas of the brain are the same areas of the brain that are responsible for memory formation, for our emotions, for our taste, for smell. Those very areas of the brain that are responsible for the things that seem to be most impaired by those studies that I just showed you, and not an inconsequential number. And note that the majority of these study subjects, it was I think pretty close to 90%, were not hospitalized. They had outpatient COVID, and they had objective measures of shrinkage of the gray matter of their brain in the period of time from their earlier MRI scan to after their COVID diagnosis, which was not seen in the non-COVID infected subjects. This is bearing out in other objective measures of brain function. So we can do what's called neuropsychiatric testing. These are formal, standardized tests for attention, working memory, processing speed, something called executive functioning, category fluency, and memory recall. And here they, in a study of over 700 people with COVID, blue being hospitalized, red being outpatients with COVID, they looked at what % of them had objective evidence of impairment in any one of these areas greater than 1.5 standard deviations below the mean for their normal age sex-matched counterparts. And you can see, particularly hospitalized people had substantially higher rates of impairment than what would be normal controls for their age and sex and underlying health status. But even the outpatients had 5 to 15% of these outpatients had objective evidence of impairment on these formal tests of neuropsychiatric functioning. Again, this should give us, I think, great pause for kind of letting COVID just go. Another similar study, and I can't remember, I believe this one is being conducted by Johns Hopkins University, and they're following a group of indigenous people in, I think this is in Ecuador, called the Atahualpa Project. And they've been following this group of people for different health outcomes over time, including measures of memory. So there's a standardized tool called the MoCA score, which is the Montreal Cognitive Assessment Tool that is used to kind of track memory impairment or early signs of dementia. And they found, I think this was might have been an older group. I don't remember the ages on these. But there's normal decline that you see over time. And this is the blue line here of non-SARS-CoV-2 infected subjects. But in those that had SARS-CoV-2 infection, they had a substantially higher drop in their MoCA score, indicating a significant drop in memory or cognitive function compared to their non-SARS-CoV-2 infected counterparts, an 18-fold greater risk of having a greater drop in this function. And this wasn't belief here. This was based on serology. Did they have a positive antibody or negative antibody test for SARS-CoV-2? Loss of taste and smell, really common COVID-19 finding. I'm sure a lot of you know people or maybe experiencing this yourself. This was a prospective study looking 5 to 6 days after a COVID diagnosis in 283 patients from Italy. There is apparently a standardized scale or scoring system for smell called the SNOT-22 symptom score. 64% of these subjects had some alteration in taste or smell. 50% were moderate to severe, an additional 14% mild to light. About 5% of these people had persistent smell abnormalities lingering beyond 3 months. Here was a study of loss of smell in healthy healthcare workers after mild outpatient COVID-19. Here looking at 2 months, 4 months, and 8 months out, a bit higher than that other study I just showed you, almost 9% still experiencing some degree of loss of smell after their outpatient COVID diagnosis in this healthy healthcare worker study group. Here, we're talking about losing one of your five senses in almost 10% going out to 8 months. Now, why might this be happening, these different effects on the brain? There's hypotheses that vary on this, that it might be direct infection of the brain, that SARS-CoV-2 might get into the brain. There's a little bit of evidence for that. There's a hypothesis that this might be due to autoimmunity, meaning the antibody response to the infection may inadvertently attack brain tissue or affect brain tissue. Or it may be that inflammation induced by the COVID infection may inadvertently affect the brain. The evidence is probably growing for this hypothesis or this model, that SARS-CoV-2 infection or COVID-19 syndrome comes with a very inflammatory response, can do all kinds of different things in the body, and this substantial inflammatory response can cause its own inadvertent effects on the brain. There's a good animal model for this, that it causes potentially even some damage to the brain, similar to what we actually see with people undergoing chemotherapy. We sometimes talk about chemo brain. The effects in this animal, a mouse model of COVID-19 infection and the induced inflammation in this animal model in mice looks very similar to chemo brain. There's also some data in humans that suggests this is maybe the most likely pathway. Some of you may, so I think there's some reason to kind of be concerned about what does that mean for us in the long term. Some of you may remember the movie Awakenings with Robert De Niro and Robin Williams, based on a true story, which is actually based on the book by neurologist Oliver Sacks called Awakenings, which was about a doctor's hypothesis that some people in basically nursing homes who looked almost like they were in a persistent vegetative state, almost like a comatose state, might be sort of an advanced form of Parkinson's disease. And indeed, when this doctor researcher investigated this in one subject, this person sort of came to life, if you will. That's why the title Awakenings. What people may not know is that this, based on a true story, was that these severe Parkinson's patients, often kind of bound up in nursing homes, was in the wake of people who had the Spanish flu in 1918. And there's a speculated connection between what that Spanish flu infection did to some people in causing later, often decades later, Parkinson's disease. That has been looked at further now. This was a very recent study just published last year, just a little over a month ago, looking at the long-term risk of Parkinson's disease following influenza and other infections. And the putative mechanism for this is the inflammatory state that may come from sometimes a severe influenza infection that may predispose people to effects on the brain decades down the line, leading to Parkinson's disease. Might this be a problem with COVID-19? It induces an even greater inflammatory response than influenza does. I don't know that yet, but when I hear people who are worried about what might the long-term complications of the vaccine be, which we're finding no evidence of, really should be equally worried about what's the long-term consequences of a COVID-19 infection that we don't know. We know several things that I've already showed you, and there may be others that down the road that that we have reason to believe could be a potential problem. In this study of the link between prior influenza and Parkinson's disease, it almost doubled your risk, a 1.91 odds ratio. So it's an almost doubling of risk for Parkinson's disease if you had an influenza infection 15 or more years before. So these kinds of things, we don't know when we see inflammation in the lungs, inflammation that affects the brain, inflammation that may affect the heart. What will these do to us down the road? So speaking of the heart, what are the COVID effects on the heart? We know from several studies that there's evidence of myocardial injury. We can see this by hospitalized patients who have a troponin elevation. Troponin is one of the enzymes in the heart muscle. 25 to 35% of hospitalized patients will have an elevated troponin level, meaning that it looks like there's some injury to the heart. if they have that troponin elevation, it predicts a worse outcome, almost a 10-fold increased likelihood of a bad outcome from that hospitalization. Heart arrhythmias like atrial fibrillation in up to 11% of COVID hospitalized patients, and other arrhythmias in 7 to 17%. Studies from France and Italy showed that 52 to 60% increase in out-of-hospital cardiac arrest during their initial COVID wave. There may be a variety of reasons for that, but some of that may be because of the direct effects on the heart. Other studies have shown increased risk of heart attacks in people who have COVID. And then there might be direct heart inflammation or myocarditis. That means inflammation of the heart. This was a small study out of Germany, 100 patients looking at people who had, for the most part, mild COVID, some with hospitalization, but 2/3 who had COVID at home. Actually, 18 of the 100 had no symptoms at all. 49 were mild to moderate. And they did a kind of a fancy MRI scan of the heart to look for inflammation of the heart, 64 to 92 days out from their COVID infection. 78% had evidence of inflammation of the heart, or prior inflammation of the heart. There's a type of finding that you can see on there called late gadolinium enhancement. 60% had evidence of persistent inflammation of the heart. It's pretty high numbers. It's a small study. We take it a bit with a grain of salt, but it's notable. And these abnormalities persisted beyond 3 months. Another study looking at Big Ten athletes after recent SARS-CoV-2 infections. So these are healthy, strapping college students, both male and female. They said, let's kind of take a look at this in our athletes that got SARS-CoV-2 infection. And they did a similar kind of fancy heart MRI scan in almost 1,600 athletes after they had recovered from recent SARS-CoV-2 infection. What did they find here? Well, it wasn't as high as that German study, but in this very, very healthy group of athletes with almost exclusively mild outpatient COVID, 2.3% of them had evidence of heart inflammation. That's 1 out of 43 of these athletes who had mild outpatient COVID had evidence of inflammation of the heart. Now, what does that do? We don't really know. Most of them did not have clinical evidence of myocarditis, but might this lead to scarring of the heart that may have later effects or other problems? We don't know. The kidney, there's good evidence that COVID significantly may affect the kidney. I'll just share one study here. This was a very large study of almost 90,000 veterans with COVID-19, and they compared them with 1.7 million non-infected veterans that were matched up for age and underlying health over the course of a year. And they found significant decline in kidney function. This is drop in what's called glomerular filtration rate. It's a mouthful. This is how much they drop. We usually drop a little less. Normally, we drop about a little less than 1 mil per minute of our glomerular filtration rate per year. We all have normal age-related decline, but this was substantially higher in people who were even outpatients, not hospitalized with COVID. The middle line here is hospitalized with COVID, but not with any overt kidney injury upon hospitalization. And then this third line here is people who were hospitalized and had evidence of acute kidney injury on hospitalization. All of them showed an increased level of decline in their kidney function. Notably, 35% increased risk of long-lasting kidney damage in the COVID survivors. A small portion of these veterans, 5%, had 30% decrease in their kidney function. That's basically the equivalent of 30 years of life taken off of your kidney, 30 years of normal aging on your kidney right after one, bout of a COVID infection. Now, get those numbers straight. Only 5% of them experienced that, but 5% kind of having a pretty big hit to their kidney function is not inconsequential. All right, there's also some kind of miscellaneous that I didn't put under a specific organ system effects here. So Hair loss. This actually was one that I wasn't really aware of until relatively recently. Here, Alyssa Milano, the actress, is talking about her bout of COVID infection or problems with brain fog and hair loss. And indeed, that's been reported in about 23% of people recovering 2 or more months out from their COVID, that same systematic review I showed you. So, interesting, odd finding there. Another one that, again, this sort of speculative long-term problems, this was a study that was just published in Morbidity and Mortality Weekly, looking at children under the age of 18 and their risk for developing type 1 or type 2 diabetes after a COVID diagnosis. Now, bear in mind that the risk of developing diabetes in that age group is pretty small. But what they found is if those children had a diagnosis of COVID, they had over 2.5-fold increased risk. That's 166% increased risk of subsequently being diagnosed with type 1 or type 2 diabetes. Now, this study has been rightfully criticized in that they did not adjust for known risk factors for diabetes. For example, they didn't look at obesity in these children. Was obesity more present in the group that developed diabetes versus the ones that didn't, and might it be just a function of something like obesity in this group? That criticism, hopefully the authors of this study will go back and look at that. They should be able to do that. But this still should give us a little bit of pause and concern. And the reason I say that is that this was being worried about well before. This is a study, or this is an editorial published in the New England Journal of Medicine over a year and a half ago, where diabetologists or endocrinologists that really focus their practice and their research on diabetes were wondering about this connection between a COVID diagnosis and the new onset here. They say, thus it is plausible that SARS-CoV-2 may cause pleiotropic alterations of glucose metabolism that could complicate the pathophysiology of pre-existing diabetes or lead to a new mechanism of disease. These diabetologists and researchers were concerned enough about this that they formed a registry to try and study this. So this COVID Diab registry is a international collaboration looking at entering people with new diagnoses of diabetes after COVID to try and study these people and understand this better. So again, we don't really know this for sure, but another reason like we should maybe be a little concerned about just sort of only focusing on whether COVID kills you or not, the mortality rate. There may be much more to it than just mortality. Another sort of odd finding, this was a Cleveland Clinic study, not very large, but they found after adjusting for age, body mass index or weight, mental health issues, the risk of erectile dysfunction was 5.7-fold higher in men who had COVID versus their non-COVID infected counterparts. And I just saw another study looking at this from the University of Florida, found pretty much the same thing, although not quite as high, only a 3-fold increased risk. But nevertheless, an increased risk of what appears to be erectile dysfunction after COVID-19. And they're speculating a variety of different potential mechanisms for that, but it's not really known yet or understood. A couple of studies that one very recent that I found very interesting was, does COVID-19 infection potentially affect athletic performance? So this study was done in elite soccer players in the European leagues. And they have a lot of data on these soccer players. They track their athletic performance. For example, their endurance on the field, so how long they last on the field before subbing out, how they're performing on the team, and therefore how likely they are to be picked to be starters, and their pass performance. So they track things like how accurate they are with their passing. They had this sort of data before the COVID epidemic in these players, and they had it then afterwards. And what did they find? Looking at the COVID infected players, and so they're serving as their own control because of their baseline data. They looked at their likelihood to be put into play. They looked at their minutes on the field. They looked at their pass performance, and they looked at their team pass performance. And what did they find? They found that the players who had COVID, certainly after the acute infection, were much less likely to be picked to play. That's understandable. They're acutely ill. But even out to 225 days out, so we're talking about like 8+ months out from their COVID infection, they were still much less likely to be picked to play. They were less likely to, they spent less time on the field, meaning they lasted less, they had less endurance on the field. Their pass accuracy went down, and it stayed down out to 8+ months after their COVID infection. And that didn't happen when they had other respiratory infections in the past. So when they get a cold or a bronchitis or the flu, it didn't really affect their pass accuracy. This has to make you wonder a little bit, is it that effect on the brain that may be affecting that? And when they looked at pass accuracy by teams, the teams in the highest quartile of number of players who had COVID had the worst drop in pass accuracy over time, where the teams that had the lowest rates of COVID-infected players didn't have any substantial change in their pass accuracy as a team. Interesting, a notable finding. Another one that looked at Swiss Army recruits. So these are young men, healthy, fit, and they track these men for their aerobic fitness. The usual measure of this is something called VO2 max, which is a measure of oxygen consumption and a kind of standard measure of cardiorespiratory fitness. Normally, these Army recruits improve as they go through basic training over time. So they looked at these military recruits and had their VO2 max at baseline, and then looked at that VO2 max after a COVID infection, typically 1 to 2 months after their COVID-19 infection. The gray here is the recruits that didn't have SARS-CoV-2 infection, really no change in their exercise capacity 1 to 2 months out. People who had asymptomatic infection, a teeny drop, but it was not statistically significant. But those that had a symptomatic COVID infection had a statistically significant drop in their oxygen carrying capacity in cardiorespiratory fitness 1 to 2 months out. So when I've had to give talks to our NDSU athletes, and I've kind of pointed out, like, you may have concerns about side effects of the vaccine, but you should equally and maybe greater have concerns about what this may do to your athletic performance. And I have a number of other studies and examples of what this might do to athletes. So trying to look ahead to our crystal ball of what this may mean at a population level, we've had almost 61 million cases of COVID or SARS-CoV-2 infection in the United States. That is people who show up to be tested. The percentage of that is probably considerably higher because not everybody gets tested, obviously. The seroprevalence, meaning antibody test positivity, is being tracked through a couple of different ways. Blood donors, people who give blood, in clinical settings. We have data through the end of October, so not real current yet, but it was quite variable on evidence of prior infection. Low of only 7% showing evidence of prior infection in Vermont, a high of 50% showing evidence of prior infection in Texas. US average is about 31%. In North Dakota, in the blood donor survey, we had about almost 38% of people showing evidence of antibodies to prior infection at the end of October. We don't know where that's at yet. But we've got a lot of people who've had infection in the United States, and after this Omicron surge, it's going to be a whole lot more. We have pretty good estimates that somewhere around 3+ million people have been hospitalized with COVID. So out of all those cases, out of all of those hospitalizations, how many of them are going to have long COVID? We need, I think, better quality data to give us a better accurate estimate of this. But from the data I've shown you, it's not unlikely to be quite substantial in the neighborhood of millions, perhaps tens of millions of people having one or more of these symptoms lingering on for months to even a year or more out. So finishing with management of long COVID. How do we manage this? Well, I mean, the best thing is to not get it in the first place. And so vaccination is your first best line of defense. Vaccinated with breakthrough infections is at a substantially lower risk of developing long COVID. I'll show you that data here in just a second. I don't know whether early diagnosis and treatment might decrease the risk of long COVID. We need to see some data on that, but it's reasonable to expect that preventing it from progressing to a more severe case of COVID-19 may very well decrease the likelihood of long-lasting or lingering symptoms. If the person goes on to unfortunately develop long COVID symptoms, we want to have a multidisciplinary, comprehensive medical assessment, and it's often involving several different professionals in a team to try and manage these folks. Now, what about vaccination in long COVID? This was a study that was published in The Lancet, and it looked at a risk of things like hospitalization, lots of symptoms, and here in particular, symptoms lasting more than 28 days. So this is symptoms lasting more than a month. And what's your odds of having that if you're vaccinated with 2 doses or 1 dose or not? And what they found here is basically almost a 50% decrease overall if you're 2-dose. Now this is 2-dose vaccinated, not boosted, but almost a 50% decrease in persistent symptoms beyond a month in those who were vaccinated. A much more recent study just out, it's still in preprint, not peer reviewed yet, but this is from a respectable research group in Israel. They looked at a variety of long COVID symptoms here. So you can see fatigue, headache, weakness, muscle pain, loss of concentration, hair loss, etc. It looks like a little bit of a jumble here, but kind of focus on this. And the light blue is the rate of these problems or symptoms in unvaccinated people. The green is the rate of those symptoms in vaccinated with 1 dose. And these are people who got an infection. So they either had infection without vaccination or a breakthrough infection after vaccination. So, and then what happens to people who got a breakthrough infection after 2 doses of the vaccine, and what happens, and what are these symptoms just like in the general population and people who aren't infected at all? So first, just take note that actually a lot of these subjective symptoms are common. If I polled our 430 participants today, are you feeling fatigued? Do you have any headache? Do you feel a little achy, or you having trouble concentrating? Lots of people complain of these symptoms just in the background. But you can see that unvaccinated people and first-time vaccinated people have these problems at a much higher rate than uninfected people. But vaccinated with 2-dose is the same or lower than people who never had any infection at all. So it basically, and so 2-dose vaccination reduces the likelihood of any of these symptoms by 54 to 83% compared to an unvaccinated person, and basically puts it in the same ballpark as if you'd never had a COVID infection at all. So that to me is very good news, and that's with 2 doses. We might expect this to be as good or better with 3-dose vaccination. We don't yet have data on Omicron, on whether that's more or less likely to induce long COVID symptoms. It's not been around long enough, but because it seems to be less virulent overall, we would expect it to maybe be less. And again, vaccination might be expected to reduce that to really as though you did not have any infection at all as far as long COVID. Treatments, we have several approved treatments. One FDA approved. These others are authorized, I should say, authorized treatments. Monoclonal antibodies, molnupiravir, Paxlovid. These 2 monoclonal antibodies and Paxlovid showing really marked improvements in decreasing your likelihood of progressing to severe disease. Unfortunately, they are extremely short supply right now. There's lots of efforts to improve production of these, but right now they are essentially being rationed for the people who are most at risk. Molnupiravir is a little bit more available, but it's not quite as good, only about a 30% reduction in progression to severe disease. But we might expect as these therapies come out and become more available, finding out if you have COVID, getting tested early, getting treated early, we might expect to reduce the likelihood of developing long COVID symptoms, although we don't have data for that yet. So I'm speculating on that. How do we manage these patients once they have developed long COVID? This is often a multidisciplinary team approach, usually kind of quarterbacked by a primary care physician, where they need to consider early rehab, patient education, maybe enrollment in clinical research studies, and active engagement with patient advocacy groups. But we might be pulling in specialists from kidney, clotting disorders, pulmonary and cardiovascular, and neurology and psychiatry. All of these different specialties may need to be pulled in to manage these variety of different problems and symptoms. I'll just finish for the healthcare workers on, and particularly the providers who are on, two resources you may want to find and download for yourself. One of these is a recent clinical guideline from the American Academy of Physical Medicine and Rehab. It's titled A Multidisciplinary Collaborative Consensus Guidance Statement on the Assessment and Treatment of Fatigue, the most common symptom, in Post-Acute Sequelae of SARS-CoV-2, or PASC. So it's a nice guideline on how to kind of measure, track this, and help these patients manage their fatigue. Out of the UK, they have a guideline called a Multidisciplinary National Health Service COVID-19 service to manage post-COVID-19 syndrome in the community. It's a very comprehensive guideline on how to track with standardized tools, a plethora of the symptoms and problems I just talked about, and it gives very practical advice on how to try and help people manage and navigate their way through those symptoms and problems. I'll mention just one of these, and that is the treatment of post-viral olfactory dysfunction. This is the loss of smell. One of the most troubling and nuisance problems to people. First is a trial of nasal steroids may help people with this. And it's worth a try. It has a small but measurable increase in restoration of smell. And then there's what's kind of being called this physical therapy for the nose. And this is actually smell training. And what they do is they line these people up with smells that are familiar, certain essential oils or herbs that they have them sniff for about 20 seconds while trying to remember what that smell was like, recalling the memory. And they tell them to do that twice daily for actually 4 to 6 months. Most commonly used are essential oils of rose, lemon, clove, and eucalyptus. And a review on studies on this showed that this can help. This can help people restore some of their sense of smell. So it's worth a try. So just to summarize here, PASC or long COVID appears to be common even among outpatients and even among young adults. The true incidence needs better defining with more controlled studies. Long-term effects on the central nervous system, kidney, heart, and lung are yet to be realized. And given the enormous attack rate from COVID-19, especially with this Omicron surge, I think we can expect major impacts on clinical practice and public health. Vaccination and early treatment are probably going to be the best means of prevention. And for those unfortunate patients that go on to develop long COVID symptoms, they are most likely to benefit from a comprehensive assessment and the multidisciplinary approach. So for those who are wanting continuing medical education credits for this, please go in the chat, click on the link here for taking the post-training assessment so that we can get you that CME. And I'll stop there to take any questions. So I'm going to stop sharing, kind of see if my video will come up, which it still cannot. So you get my picture still. Sorry about that. So
Thank you very much, Dr. Carson.
Yeah.
Yes, I apologize for the video issues that we have been having, but we do have a first question, and that is actually related to populations that have experienced historical trauma. And they're wondering, considering the impacts of COVID on mental health, if populations that have experienced historical trauma could be a potential research area, and wonders if the epigenetics related to the impacts of historical trauma could be a protective or risk factor in regards to the impact on mental health and COVID.
So the answer to could they be, I would say certainly yes. And we would almost always say yes to like, could this be a good research topic? I don't know of any particular data on specific to populations that have experienced historical trauma. We do know that a lot of these populations, so African American, Hispanic community, American Indians, do seem to suffer greater likelihood of going on to more severe outcomes from COVID. And in fact, that has been in some of the criteria for the rationing of, for example, monoclonal antibodies. It's counted in sort of the point score that you get for being eligible for those monoclonal antibodies. But most certainly, those would be good topics for researchers that are interested in that line of research.
Thank you. Our next question is again related to the cognitive issues, and they're wondering, memory deficits and difficulty concentrating are both cognitive impairment. What other cognitive impairments have been seen for PACS patients?
So you can see that, for example, more severely affected patients, patients who are hospitalized in the ICU, may develop a overt encephalopathy. So, I mean, delirium, severe cognitive impairment during that time. And it's unclear whether that's a direct effect of COVID or the effect of severe critical illness, which this can happen in anybody with severe critical illness. We see that the increased risk of things like stroke is higher. We see that there may be effects on peripheral nerves. I think we're only beginning to understand the risks to the nervous system and how significant they may be. But most of the stuff that I've been kind of reading about this have to do with these subtle to maybe not so subtle impairments in cognition. Now, because I've been reading this literature, I regularly am asking like my friends and family who've had COVID, hey, how's your thinking? How do you feel like your concentration is? How your brain function? Most have told me that they don't notice something. So I do think there's still some selection bias in these studies that is suggesting this may be more prevalent than it actually is, but there's clearly something out there, and I think something to be very cautious about and wanting to try and prevent. But I think we're still at the beginning of our understanding of this and what's causing it and how extensive it may be.
Okay, our next question is related to on those individuals that have had COVID twice. Is there any research related to the long-term impacts on those individuals?
Not that I'm aware of. We do know, and I've said this in other talks, that a COVID infection is about the equivalent of immunity, maybe even a hair better than 2 doses of the vaccine. So, a COVID infection, we would predict, well, actually we know, gives you about as much protection against subsequent hospitalization, for example, and against subsequent infection as 2 doses of the vaccine. I would expect, even though we don't have studies on this, I would therefore expect, don't know this, that it would likely give you a similar protection against long COVID from your second infection. Now, that doesn't, whatever you got from the first infection is probably there, but the second infection is likely to be more mild and not lead to as bad of sequelae. But we don't know that yet. That hasn't been studied as far as I know.
Okay, the next question is related to smooth muscle organs. So they're wondering about the extent of damage on all smooth muscle organs, and are there any data or hypotheses out there? For example, the GI tract, as well as female reproductive system changes.
Yeah, both good questions. So I didn't show the digestive system effects from that comprehensive systematic review, and they are there somewhere in the neighborhood of about 5 to 20% of people have ongoing GI effects, whether that's loss of appetite, sort of bowel irregularities, nausea. Those have been reported. And actually, you sometimes see in children a higher likelihood of presenting with GI symptoms as opposed to respiratory symptoms. So those, now whether that's a direct effect on smooth muscle or not, I don't know. But and I haven't read that or seen that, but the GI system has been reported to have some of these lingering effects in a not inconsequential percentage of people. Like I said, about in the neighborhood of 5 to 20% having ongoing. As far as the reproductive system, first of all, the fertility question, with the vaccine, not there, don't see it, nothing coming up. Now, several good studies showing no effect on fertility. Same is true as far as I can see for COVID on female reproduction. There was one study looking at male fertility and some changes in sperm counts transiently for weeks to months after a COVID infection, but I think that for the most part returns to normal. Both the vaccine and the virus seem to cause menstrual irregularities for about 1 month or one cycle in a not inconsequential percentage of women too. And then that seems to revert back to normal after typically one cycle of irregularity, usually meaning a change in the duration of a woman's period. But nothing that seems to be lingering or lasting in the reproductive system.
Okay, our next question is related to children and those below the age of vaccine. Can you speak to any of the research that might be out on the long-term impacts among those populations?
Yeah, that's a great question, very important question. A very active area of research. Again, another large NIH trial is ongoing to looking at a long COVID in children. A kind of earlier sort of low to medium quality study suggested that it might be in the neighborhood of around 5 to 7% of children may experience one or more long COVID symptoms. That's significantly lower than what's being reported in adults, but that's not inconsequential. We will have better data when this NIH-funded study is completed, and my guess is that might be giving a preliminary look at data in the next few months. I think the UK is doing something similar. So it's a concern. And I think one of the greatest concerns, we have now is that I think a lot of us feel like we hopefully can kind of start moving on with our lives as vaccines are available to most everybody, and boosting seems to protect against severe illness quite well, 90% protection in people who are 3-dose vaccinated. The unfortunate thing is that we don't yet have any approval or authorization for children under the age of 5. And the one Pfizer study that was just done, the phase, I believe it was phase 2, maybe phase 3 data, and Kylie can correct me if I'm wrong on this, where they gave a much lower dose of the Pfizer mRNA, did not show protective benefit in there. So it might have been too low a dose. So we're kind of back to trying to figure out what to do for kids under 5. And I think that's the biggest conundrum right now, is because those kids really aren't yet protected. Fortunately, most of them do quite well, but not all. And so that's, I think, our biggest conundrum right now. I did hear that Dr. Fauci made on some announcement that they may be giving an authorization to vaccine in 5 and under, but I don't know what they would be basing that on, because I haven't seen any new data yet, unless there is some newer data that they're about to release. So we'll see.
Okay. If it's plausible for the antibodies to do damage to the brain and cause the long-term cognitive issues that you were speaking of, could the antibodies produced from the vaccine cause any issues?
So the autoimmunity question, or auto antibodies, so a couple things there. One is that's the least plausible mechanism that's been shown so far, the least amount of evidence for it, that it's autoimmunity. And bear in mind that we make only a select handful of antibodies to spike protein from the vaccine, where you make a huge plethora of antibodies to the virus. So you have much more antibodies that have the potential to cross-react with our normal tissue. The predominant mechanism of action that seems to be suggesting the cause for this impairment is the inflammatory response. So I think that's going to be, that's bearing out to have greater body of evidence for it. And so I mean, and we're not seeing that. I mean, we're not seeing cognitive impairment in people after the vaccine, and there's all kinds of things that are being monitored and studied and so on. And that's just not being seen. And autoimmunity problems are usually will declare themselves within the first 4 weeks after vaccination. That's when you make the most antibodies. And so if you have autoimmune problems, like we sometimes see rarely Guillain-Barré syndrome, for example, after some vaccines, that usually occurs very acutely. We don't see it later as the antibody levels are fading away. So I don't think that's going to be an issue.
The next question is related to those who might be most likely to get long COVID. Is there any current data on who is most likely to get long COVID beyond vaccination status? This person had heard somewhere, potentially it was women in their 30s and 40s. Is there any merit to that information?
That's a good question. So I should know the answer to that. It would not surprise me if that's accurate, because when you look at problems like what's sometimes referred to as chronic fatigue syndrome, fibromyalgia, again, sort of poorly understood chronic health problems that sometimes may follow like an acute infection or viral illness, it is much more common in women. I should know this data for post-COVID, and I suspect that person is right because those problems are typically more common in women, and the mechanism of that is not understood. It's really not understood why.
Okay, this next question is related to skin disorders. So on the slide, or rashes. So on the slide with skin disorders, you spoke specifically about hair loss, and they mentioned that she might have missed it if you did speak about skin rashes, but is there any connection to long COVID and skin rashes?
Yeah, that was reported there, and my apologies, I hadn't looked at that more deeply, like what rash or what kind of skin problems. And I think if I do any kind of update on this sort of thing, I'll try and do that to know it better. And if people have some observations, they might post those. I haven't seen this or heard any of my colleagues talking about it specifically, but you are correct. That was reported, and I think it was in the neighborhood of like 5 to 10% of people reporting some skin problems or skin rashes 1 or more months after, or more than 2 months after COVID. But I apologize, I can't be more specific than that.
So this is the same individual, and they were actually also wondering about if there's any information regarding skin rashes in those that received the mRNA vaccine.
So you can have a generalized rash after the mRNA vaccines. You can have something that's sort of colloquially called Moderna arm, where you get a sort of big, swollen, red, almost looks like cellulitis or infection of the arm. This is thought to be what we call an Arthus reaction, or a delayed type hypersensitivity. It's sort of a slow allergic reaction. And that can look really scary. You can kind of see this big kind of red, inflamed, sore arm. It's fairly rare, but I've had friends who've had it. I've seen people with it. I've seen pictures of it. Had somebody show me their arm in an airport once to show this to me. That's fairly benign. It will resolve on its own, and it actually you're not at much higher risk getting a second shot. So if that happened with the first one, you can still get a second shot, and the vast majority of those people do okay. But there are sort of non-specific rashes reported after the mRNA vaccines. They are not a contraindication to subsequent doses. Most people do just fine.
Okay, the next question.
The one qualifier I would put with that is hives. So that is a true, what we call type 1 hypersensitivity reaction. So that, if you're not certain what that's like, you want the doctor to look at that, but that's, the sort of raised welts that are very itchy, often accompanied by other signs of type 1 hypersensitivity. So lip swelling, tongue swelling, throat swelling, wheezing, that sort of thing. So that is a contraindication to subsequent doses. That's a true immediate hypersensitivity reaction.
Thank you. The next question is related to individuals with risky behaviors. Have you seen any data with people with long COVID and those who engage in risky behaviors such as tobacco use?
Have not. Early on, when the epidemic was first being described in China, there was noted that males seemed to have a much higher risk of severe infection, and it was speculated that was because males smoke a lot more in China. Smoking has not borne out to be a marked risk factor, even though you think it should, that because it's a marked risk factor for a lot of other respiratory infections and things like pneumococcal pneumonia. And so on. In fact, smoking is an indication for pneumococcal vaccine. That doesn't seem to be bearing out as a predictor of severe disease in COVID, at least as far as I'm aware.
I think I'm going to take the next two, Dr. Carson. I'm wondering if you can tell us if there's any data on how common long COVID is with reinfection. Is it more common, less common than your primary infection? Is there any data on that?
To my knowledge, no data. As I kind of speculated earlier, I would speculate because prior infection gives about the same level of protection against hospitalization as a 2-dose vaccine series. And a 2-dose vaccine series gives you protection against long COVID, that if you didn't get long COVID with your first infection, I would speculate you're less likely to get it with that second infection. But I don't know that, and I don't know any data that's out there on that. But that's my guess, my best guess.
How about the prevalence of long COVID following an Omicron infection versus Delta, Alpha, or even the ancestral strain of SARS-CoV-2?
Yeah, can't say that because it hasn't been around long enough. So it really was first recognized coming out of South Africa in November. If you kind of consider that we kind of define now World Health Organization definition as 3 months or more out, we just don't have any data on Omicron yet. I would speculate that it hopefully will be less because it does seem to be less likely to put you in the hospital than the earlier variants. But it isn't going to be zero. I can almost assure people it won't be zero, but hopefully it will be less. We don't know yet.
Okay, our next question is related to the last piece of information that you had provided on the treatments. And it is, have the MAB or Paxlovid been shown to be effective in vaccinated or just unvaccinated individuals?
Oh, there's no reason to think it would not be effective in vaccinated. Now, it's not going to have that same degree of protection because a vaccinated person is already much less likely to progress to severe disease. With Omicron, with the Omicron wave, where we have lost some of the protective effectiveness of vaccines, a 3-dose vaccinated person has 90% protection against progressing to severe disease. A 2-dose vaccinated person has somewhere in the neighborhood of 50 to 70% protection of progressing to severe disease. Paxlovid has about 90% protection against progressing to severe disease. So you already have a markedly reduced risk, and then you would presumably decrease that risk that much further by taking the Paxlovid. It's not a contraindication to, certainly getting those drugs, hopefully when they're more available. But it would be additive to the protective effect of your vaccination, and no reason to think it wouldn't work there. And there's every reason to expect the Paxlovid will work in the Omicron. Now, sadly, there's about 6 different monoclonal antibodies out there. Only, I think it's like 3 maybe that are available in the US, 3 or 4 that are available in the US. Unfortunately, really only one of those, one called sotrovimab, is really the only one that works against Omicron. So we're in extremely short supply of monoclonal antibodies that are effective against the current wave, unfortunately.
Okay, well, I'd just like to thank you. That would be our last question. Thank you so much for presenting today on long haul COVID. And as a reminder, this presentation has been recorded and will be available on the CIRE YouTube page. And I believe that information has been provided within the chat. But if you do have any questions about where to find that recording, please feel free to contact CIRE.